Good afternoon. Welcome to NAMI Illinois Conference. Our session today, OCD in the COVID era, Lessons to be Learned. I'm your host, Tina Mackey from NAMI Will Grundy. Our speaker today is Jeremy Fine, a PhD student at the University of North Carolina. Jeremy was part of a panel discussion last year at the state conference and clearly made such an impression that NAMI Illinois has invited him back this year to present his own session. So Jeremy, please begin when you're ready.
Yeah, thank you for that lovely introduction, Tina. So as Tina said, my name is Jeremy. I'm currently an MD PhD candidate at UNC Chapel Hill, go Heels. And I'll tell you a little bit more about what that entails in a sec. And I'm going to be presenting about OCD in general and talking a little bit more about what OCD is like during COVID and how we can all learn from that. So I'm going to start with sharing a little bit about me and telling a little bit of my mental health story. After that, I'm going to talk about what is OCD and just kind of break it down, even though I'm sure plenty of people here do have a good understanding of it. I have a certain way I do like explaining it. Why is OCD important to study in particular? How is COVID affecting mental health? And, that's something we can all relate to right now. And a lot of those will be things that we've all experienced since March. COVID anxiety versus OCD. So how do those look similar or different, and what similarities can we draw? OCD treatment. And then lastly, how can we apply these treatments for all of us to deal with the tremendous amount of anxiety that we are currently facing on a daily basis? Because the world is an anxious place right now, and reasonably so. So who am I? This is me growing up. I think I was 9 in that picture. So I am from the Chicagoland area, born and raised. I went to Glenbrook South High School. And after that, I attended undergrad at WashU in St. Louis, where I studied, my major was called PNP. It was philosophy, neuroscience, and psychology. And then I minored in music. And following that, I took a gap year while I was applying to medical school. And so, like I mentioned earlier, the degree I'm doing right now is a combined MD PhD degree, which, to make a long story short, is just like a ton of school. And so the way that works is you do the first 2 years of medical school, then there's a PhD, and then you finish medical school after the fact. So it's called a 2-4-2 program, and it's funded by the government. So I'm technically employed by the NIH for all of my disclosures. So this is my first year in the program. So right now I'm a medical student. So after this, I'm going to go back to studying hematology and oncology. It is difficult, but it's going well so far. And I moved to North Carolina. It's a new home for me. But after all this is over, I do plan to come back to Illinois. Okay, so why am I talking about OCD today? Well, in addition to it being just one of my main academic interests, I also live with OCD. Ooh, I saw somebody raise their hand. Let's see. I'm not 100% sure what to do with that, Tina.
Yeah, that's okay. Why don't you proceed, and folks, if you have questions, go ahead and put them in chat, and then we'll hold them for the Q&A.
Oh, yeah, and if there are, I'm also happy to answer questions as we go through the chat. If there's something that seems like pertinent to what I'm talking about at the moment, that you feel free to interrupt me if you would like, Tina.
Okay.
So my story begins my sophomore year of college. Well, I was sitting in my sophomore year dorm room eating Thai food with my girlfriend at the time. I had never had any mental health condition in my entire life. Pretty much been a normal, happy-go-lucky kid. But then I vividly remember the first time I had a thought get stuck. And it was really weird. I was so taken aback. I remember my girlfriend told a joke and I laughed. And then like out of nowhere, I had this thought and all these alarm bells go off in my head. And the thought was, how do I know that joke was funny? And, you know, I had the same reaction probably as a lot of you right now. I was like, well, that's, that's not how jokes work. A joke is funny, you laugh, and then you move on. But I just started experiencing an incredible amount of anxiety associated with this question. Like, okay, how do I know she's funny? And I want to be with somebody funny. And if she's not funny, how do I know I want to be with her? And then I started to feel guilty that I was thinking these things. Um, but after that night, I kind of just said like, okay, that was weird. Let's just move on. I'm going to go to bed. But then over the course of the semester, more thoughts started getting stuck. And I also started experiencing a tremendous amount of guilt associated with them. So a lot of them were, how do I know that I want to be with this person? Or how do I know that, that I'm going to be faithful to this person? Thoughts that I felt horrible about because I didn't want to be having them. And they went directly against my morals and my belief system. And so, you know, imagine you're sitting somewhere, you have this thought that pops into your head that won't go away. Your natural reaction is going to be to think about it or to do something in response to it. So for me, that was trying to like solve my thoughts. So let's say I would have that thought like, okay, how do I know she's funny? And all these alarm bells would be going off in my head and they really made me feel the need to take action and answer the question. So I would say, okay, here are all the times in the past that she's been funny. Here are reasons I think she's funny. Okay, maybe here's a reason that she's not funny. Okay, wait, here's another reason she is funny. All right, it's settled. She's funny. Until 5 minutes later, the thought came back with the same amount of just dread and anxiety. Um, and this went on for months. I remember one morning I woke up 4 hours early to try and get schoolwork done. And 3 hours and 40 minutes of that was spent curled up in a ball in my bed, trying to answer these questions that were unanswerable. They just physically wouldn't go away. I felt like there was something that was new in my brain that I just wanted to take out. I didn't know what to do. And like I said, I was horribly guilty about these thoughts because I didn't want them. They made me feel bad because I was having negative, persistent thoughts about somebody I cared about. And slowly, as I started to get really depressed over the semester. I wasn't able to do the things I enjoyed anymore. I could barely even hold a conversation with a friend by like February. Um, until it was at this point in my story where I was pretty desperate for answers because this had gone from 0 to 100 for me super quickly. And I was probably spending 90% of my day stuck in my head at this point, just like very non-functional. I was not living a life worth living. And I knew if I had to go on like 6 more months like that, I would have ended up taking my own life because I wasn't able to enjoy life in the slightest. It was horrible. So I started looking for answers. And luckily, as I mentioned, I was a psychology and neuroscience student. So I kind of had some inkling as to what might be going on. And I ended up on Reddit on a forum about OCD. Uh, and in my mind, even though I was a psychology student, I thought, okay, there's no way I can have that because my room is messy as hell. I'm not super organized and I don't wash my hands a lot. But I was actually totally wrong. So now I'm going to really briefly go into describing what OCD is. So I like to call OCD sticky brain disease. And like I mentioned at the beginning, it all starts with a thought. So this guy is supposed to be having a thought. And specifically, the kind of thought OCD is associated with is called an intrusive thought. So what's an intrusive thought? Intrusive thoughts are thoughts that every single person gets. Uh, you may not remember them because the vast majority of the time in people whose brains aren't sticky, they don't get stuck with them. So let me give you an example. If you've ever walked past a store and thought, you looked at something in the window and you had a thought, oh, I could steal that right now. Like, I hope you don't steal it because that's illegal. But you have that thought and that's okay. It's just a thought. Or you're driving and you think, oh, I could run the person off the road next to me. Normal thoughts that everybody gets. And for most people, they're no big deal. But in OCD, your brain is incredibly sticky. These thoughts go into your head and they get stuck there. And when an intrusive thought gets stuck, it leads to an obsession, the O in OCD. So an obsession is a pattern of stuck, intrusive thoughts. Now, these thoughts can be about anything. In a subset of people with OCD, about 15%, they end up being about relationships. There's a good chunk of people who have them about their health and about contamination. So that's like the monk OCD, right? And that was the picture I had in my head when I first learned about OCD. But it really can be about anything. I remember watching a documentary once. Someone was worried about going blind, and they just had this thought that wouldn't go away, and it was associated with all these alarm bells in their head. So OCD can be about anything, and that's kind of one of the misconceptions that I like to clear up, because it looks very different a lot of the time. And one of the reasons it looks very different is because of the C. So obsessive compulsive disorder. Compulsions are what people do in response to the stuck intrusive thoughts. So like I said, I ruminated. I tried to solve these thoughts in my head for hours and hours to make them go away, but they wouldn't. They just kept coming back because that's the nature of the disease. So the nature of my compulsions were called covert, like a spy. They were in my head and nobody could see them except me. However, you might also think of like hand washing. That's an overt compulsion. You can see someone do that. So if someone has the stuck intrusive thought, I'm going to get sick, which I'll get back to that thought later today. You can imagine that irrational response to having that thought stuck in your head all day is to wash your hands. And then when it comes back, to wash your hands again. So compulsions do not necessarily have to be visible. And so the last letter is the D, is the disorder. The disorder is the cycle. It goes obsession, compulsion, obsession, compulsion, obsession, compulsion, obsession, compulsion, obsession, compulsion. And it just keeps going and going and going. Because every time an intrusive thought comes up, part of the nature of the disease, like I said, is all of these alarm bells go off in your head. You feel threatened. It's like, one way I describe it, it's like your spider sense is tingling. And everybody has that spider sense, but in OCD, it goes off at improper times and it's associated with improper situations. So that's what OCD is. Now to quickly wrap up my story before we move on. So that was sophomore year of college. I learned I had OCD. I ended up being able to see a psychiatrist despite the 3-month wait in St. Louis because we had a distant family member who was a psychiatrist who agreed that I was dealing with OCD, started seeing a therapist, got into treatment, a little bit more on treatment later, but exposure response prevention and cognitive behavioral therapy helped me tremendously. I meditate regularly now. I exercised regularly before, but I exercise even more regularly now, more for my mental health than anything. Make sure I get 8 hours of sleep a night, which is a struggle, but I really do prioritize in med school. I play music a bunch. As I said, I was a music minor. Playing guitar was been my coping mechanism my whole life, and that holds true now. And I also play the drums, which even gets more energy out. And I have a wonderful network of friends who support me. And since then, I've decided to dedicate my career to educating others about OCD and really advocating for this cause. So now with my combined degree, I plan on going into psychiatry with a PhD in public health. So I can do a lot of the public health of mental health, which is right up NAMI's alley. So I love, love, love NAMI, and I'm very excited to be here today. So a couple quick facts about OCD. It's a chronic mental illness. This is something I'm going to live with for my whole life. But that doesn't mean it's always hard. I have some weeks where it's not there at all. I have some weeks that suck, where it's hard to have OCD, but it is leagues better than it was at the beginning, thanks to all these phenomenal coping mechanisms that I have in my arsenal. And when things do get tough, I know how to handle it. 2% lifetime prevalence in adults, which is a lot higher than most people think. There's a spectrum of insight. So insight is how much people are able to recognize that their thoughts are kind of ridiculous. Like I knew every second that I had those intrusive thoughts that it was ridiculous that I was trying to solve whether or not this joke was funny. Like I could take a step back from myself and be like, this is so silly, like, but I couldn't stop. Or the person who drives around the block 27 times to make sure they didn't hit anybody, they recognize that their behavior is irrational, but they can't stop doing it because that's the only way they know how to cope with the anxiety. But there is a spectrum. Some people are closer to the other end of the spectrum, and that tends to be associated more with psychotic disorders when you don't really understand that your behavior is fully irrational. The vast majority of the time, OCD sufferers do have insight into their condition, and it usually is only with some of those like psychotic and like schizophrenic like comorbidities or associated disorders that it ends up being a lower insight presentation. So OCD patients are 10 times more likely to die by suicide and 5.5 times more likely to attempt suicide. It's really sad. And part of the reason why I talk about this is because, most people weren't as fortunate as me to be able to study psychology before they were diagnosed with a mental health condition. Most people don't know what's going on. And if you're in the half of OCD presentations that doesn't end up washing their hands all the time, or being super neat and tidy, you probably won't recognize you have this illness, which also leads to the fact that there's a 7 to 11 year period on average that people go before seeking treatment with OCD. People don't know what it is, and that includes people dealing with it. So there's a significantly reduced quality of life. Estimates vary on treatment efficacy. Treatments are generally pretty effective, but there's this concept of remission, which is kind of shaky. It's basically a certain time period. I think it's about 2 months to find like without symptoms, but OCD is usually kind of a disorder of ebbs and flows. I know if I am more stressed, my symptoms increase like clockwork. If I don't sleep, like clockwork, they go up. So why talk about OCD? I'm going to talk about these kind of quickly, but these are 2 studies I brought up about why it's important. So this one study sent vignettes describing OCD patients to American Psychological Association mental health providers. These were certified mental health providers, and all the OCD presentations varied in these ones that they sent. 360 people completed the survey. 40% of the diagnoses in this study were misidentified, and the professional was not able to correctly diagnose the patient in the vignette with OCD. And you can see the breakdown of this is that the vast majority of those who were misdiagnosed had presentations that do not align with the popular conception of OCD. 77% of individuals with obsessions relating to homosexuality were misdiagnosed. And these weren't real patients, these were vignettes. And you can easily see how that can happen, in our progressive world, which is a good thing. You can imagine if someone comes into a therapist's office saying like, hey, I'm worried I'm gay, even though I've been straight my whole life. It takes a professional with a really, keen eye to be able to tease out, okay, is this someone's sexuality that they've been repressing, or is this actually a kind of OCD associated with intrusive thoughts? It's not easy, but that's why it's really important that we do more training. A similar study, this one was actually sent to primary care physicians, so MDs, excuse me. 208 completed the survey, 50% were misidentified, same pattern as last time. Just kind of sip of water real quick. If you look at those statistics, it's not the contamination obsessions that are being misdiagnosed. And if a professional is not able to diagnose a contamination obsession, they need a little more training. Excuse me. And this is the scary part. Among the people that did misdiagnose, among the people that did misdiagnose, only half recommended cognitive behavioral therapy and less than 10% recommended SSRIs, which are both first-line treatments for OCD. So not only did the patients in these vignettes receive incorrect diagnosis, but from those, they received incorrect treatment. And treating OCD improperly, it can exacerbate symptoms. So even among those that did correctly identify, only 2/3 recommended the first-line treatment of cognitive behavioral therapy, and 35% recommended the first-line medication of selective serotonin reuptake inhibitors. And I mean, this is kind of, the rabbit hole gets worse. People who misidentified the drug prescribed antipsychotics 12.5% of the time, which, like I said, giving somebody antipsychotics who does not need them can be very dangerous. And there are a host of side effects associated with antipsychotics that we don't need to get into. And I want to briefly mention all of the articles that I'm referencing here. I cite at the bottom of the page with a link, and there I use little superscripts throughout to note which facts come from which articles. Most of them should be open access, but if anybody has any trouble accessing any of these and would like to read any of these papers later, you are welcome to send me an email and I will get that to you. So shifting gears a little bit, how is COVID affecting our collective mental health? I'm going to talk about 3 ways, but there's a million ways right now. You know, we're all living this and you can kind of imagine. So some of these are pretty easy to relate to and pretty simple. Loneliness, social distancing. I mean, the fact that it was called social distancing and not physical distancing from the beginning kind of was a self-fulfilling prophecy. We put ourselves into a little bit of this lonely place. There we go. So we're lonelier than ever right now. I cited a couple papers that have come out since the pandemic has begun, and you know, we have a lack of social support as a result of that. And we also have a lot of excess time on our hands. For me in particular, when the pandemic hit, that was one of the most challenging things because I need to keep my brain active constantly. I know when I don't, it is an opportunity for my OCD to start throwing out intrusive thoughts at me. So I really need to stay busy, and I prefer to stay busy because an idle mind for me is not ideal. So a lack of social support combined with excess time can really exacerbate people's symptoms. And OCD symptoms increase with loneliness, kind of a no-brainer fact, but it is cited. So now I'm going to talk about grief briefly. And this was actually one of the slides I learned the most from while I was researching this, is I did not know about all the different types of grief that we are dealing with right now. And I don't have anything cited here as to why grief can make mental health with people with OCD a little bit more difficult. Kind of feels like a no-brainer. But that being said, there is a little bit of a gap in the literature there. So I couldn't find anything directly showing grief to OCD symptom worsening. So one kind of loss that we're all dealing with right now is ambiguous loss. So I wrote the definition. It's loss characterized by psychological presence with physical absence or physical presence with psychological absence. So the classic case of ambiguous loss is, think of somebody that is like a soldier that's missing in action and his wife at home having to deal with the death, but it's not fully a death because he might still be alive. That's actually what a lot of us are dealing with COVID right now, in a sense. We don't know when this is going to be over. It's hard to, have this uncertainty of and not being able to come to terms with a loss because we don't know how long we will have lost what we have lost. So we have the psychological presence of all these things that we remember and enjoy doing. For me, that's going to concerts. I miss it every day. I don't know when they're going to come back. And so that ambiguous loss makes it hard. Complicated grief or complex grief is essentially grief without closure. So imagine not getting to say goodbye to your loved one can make grief a lot more to deal with. And people are experiencing that with COVID right now, unfortunately. Disenfranchised grief, this is a term I didn't know about, is grief that you are not able to socially mourn. So imagine a persecuted group would not be able to have a public funeral because of their persecution by society. We're actually having disenfranchised grief right now because of COVID. People are not able to be at the bedside next to their loved ones. We are not able to have funerals because of the gatherings. All of our grieving rituals have been put to a halt, and disenfranchised grief can make the grieving process go on longer and make it hurt more. Lastly, anticipatory grief. This is grief that hasn't happened yet. So this is kind of like the shell shock of grief, the fear of planning things in the future because so many plans have been canceled. I know my partner has definitely dealt with this. Her graduation was canceled and a bunch of things after that were canceled. And so she is reasonably hesitant to plan anything because she doesn't want to get taken away from her. And I know a lot of people who have been facing this right now. It's not only worrying about friends and family who might pass away, which of course is part of it, but it's also those life events that we might not be able to have. I haven't had my white coat ceremony yet, which is usually the beginning of medical school where you put the coat on and recite the oath. I don't know if I'm going to have that. And that anticipatory nature of kind of being a little bit hardened from all the grief and not knowing what to be excited for makes grief during COVID a little bit more challenging. Lastly, anxiety. We have all been affected by this. So, anxiety during COVID is healthy, and I will talk about that a little bit more. And one thing that can make the anxiety worse is ineffective risk communication by the media. If you haven't noticed, our media is not clear cut right now. There are facts from every side being presented as facts, when in reality there is fact out there, but there's so many different sources of information saying so many different things. And this has been shown to increase anxiety during pandemics. I think the source I cited was actually looking at the SARS pandemic in India and how the media affected anxiety during that. But there was also something I cited that has to do with COVID. And then finally, social media usage. The more you use social media during this, the more anxious you're going to be. 40% of people are dealing with a mental health condition right now. This figure is taken from the CDC. Like many Americans, I do not fully trust the CDC right now. But that being said, in the mental health domain, their information does seem pretty reliable. So that's 4 in 10 of us are reporting significant mental health symptoms right now. And social media makes that a little harder. So one suggestion is just limit your social media usage during this, or limit how often you check the news. Do it once in the morning and once at night. It's important, but it shouldn't be absorbing our lives. So how is COVID impacting OCD sufferers? I'm going to talk about 2 main ways, and I'm going to break these down. Oh, I'm sorry, I forgot I had another slide first. There's a couple ways that we've actually already been able to observe how OCD sufferers are being impacted by COVID. This really small Italian study looked at risk factors for people with OCD having worse outcomes during COVID. So this was published, I believe, in the last month. Those with contamination obsessions, so obsessions about being sick or getting sick or dirtiness, were more likely to have higher symptoms during COVID. And then very interestingly, those considered in remission before COVID were also likely to have more symptoms. So those who were doing fine before COVID hit, when COVID hit, were actually shown, again, in this very small study, so you got to take this with a massive grain of salt, but were actually shown to have more symptoms following the pandemic, which I found really interesting. So some of what I'm going to talk about in this slide is anecdotal evidence. And the source I cite here is from practitioners who compiled a bunch of anecdotal evidence. And you can imagine somebody with a contamination-related OCD, constantly worried about being sick, and then all of a sudden a pandemic hits, saying, oh my gosh, like I should have been this worried the whole time. Like, it's almost like a prepper who preps for doomsday, and then doomsday happens. Well, there's a sense of, well, I was vindicated all along. That's a little bit of a faulty example because, like I said, most of the time OCD sufferers, actually all the time, OCD sufferers do not want to have their thoughts. So they're not washing their hands because they think it's a good idea. They're washing it in order to avoid the anxiety associated with their thoughts. Now people know what it feels like to be me. Everyone is constantly on edge right now. And you can imagine that in someone with OCD, now being able to turn to their neighbors who are all constantly on edge, like they're usually used to being, there's a sense of catharsis and empathy that can be derived. If everybody has alarm bells going off in their head all the time, now people know a little bit more of what it's like to have in my daily life. And I've talked with friends with OCD also who feel like this, saying like, this time actually isn't that much worse for me, but it's great because now my friends and family know what I suffer with on a daily basis to a certain extent. And yeah, things that make life in 2020 harder for those with, or hard for all of us, make life harder for those with OCD and mental health conditions. So now I'm going to talk about how COVID anxiety, our anxiety associated with getting sick during the pandemic, kind of looks like OCD a bit. So I'm going to talk about some of those similarities and why they're similar and some of those differences and why they're different. So the first thing I'm going to talk about is intolerance of uncertainty. And the next thing I'm going to talk about is, am I sick or am I sick? And we'll see a little bit more about what that distinction means. So intolerance of uncertainty is the tendency for an individual to consider the possibility of a negative event occurring as unacceptable and threatening, irrespective of the probability of its occurrence. So let's break that down. That's essentially saying that, okay, when a person doesn't know what's going to happen, if there is an element of uncertainty, intolerance of uncertainty is immediately going to that worst outcome. It's immediately feeling incredibly anxious and kind of mentally deciding that, okay, the worst is going to happen, and that's not okay, and I need to avoid that at all cost. So there is a spectrum of intolerance of uncertainty. You don't have to have a mental health condition to be intolerant of uncertainty. And right now, intolerance of uncertainty is high because there is so much uncertainty to go around. We don't know what's going to happen next year, much less next week. You know, things are canceled all the time. Everyone, many of us may have had COVID scares where we have to cancel all of what our plans might be because we've been around somebody that might be positive. So it's very reasonable that intolerance of uncertainty would be higher right now because there is so much uncertainty, and rumination is also higher. Just thinking, oh my gosh, what if I get it? What'll it do to me? So, and again, ambiguity in the media can increase uncertainty. So intolerance of uncertainty is actually a hallmark of OCD. So this is one of those ways that someone without OCD can relate to somebody with OCD, is that someone with OCD has these thoughts constantly going around in their head that physiologically they cannot be sure they are not true because they constantly pop up. One nickname for OCD is the doubting disease, because these thoughts pop up and it is physically impossible for a sufferer to fully prove them wrong because they get stuck there and they're going to come back. And every time they come back, they're going to be associated with these alarm bells. And every time alarm bells go off in your head, there's an element of, oh my gosh, should I really be paying attention to this? You know, I have alarm bells go off in my head all the time that I've learned to totally just ignore. And that's hard. And a lot of us right now are having these alarm bells going off in our head. They might be at a proper time, it might be an improper time, but we're not always sure what to do about them. So now the next slide I was talking about is, am I sick versus am I sick? And in order to describe what that means, I need to talk about the behavioral immune system. So if you guys could, I'm about to show a couple pictures, and if you could put in the chat how they make you feel right now, I would greatly appreciate it. And then Tina could read them off to me. So how does this picture make everyone feel right now? Just throw a word in the chat. I actually might be able to see it. Nervous. Yep. Thank you, Sheila. Yeah, I mean, this makes me feel nervous too. There's too many people. Yeah, it gives me the heebie-jeebies. Claustrophobic. That makes a ton of sense. Stay away, right? Your alarm bells are going off in your head. This has showed up in some of my dreams, which have turned into nightmares. Lonely. Yeah, that's a good one too. It does make me miss that feeling. Okay, so that was the first picture. And now the second picture, yes, also not worth the event. And this is a picture of something that happened well before COVID. This is not something happening right now. And how does this picture make everybody feel? Infected, right? It makes my skin crawl. It makes me feel gross. It makes it, I feel disgusted. Yeah, sorry for that person. Afraid, good, yes. Again, this is not a picture associated with COVID in particular. This was literally just a picture of someone sneezing. Yeah, I don't even think it was a cough, it was a sneeze. And the point I'm trying to get across is, you know, that feeling of looking at a crowd and feeling nervous or afraid would not have happened in February or January or before all COVID started. You know, before we definitely had some fear associated with someone sneezing or some gross feelings of aversion to that. But now those are on steroids. You know, you see something like that and you have a visceral reaction to it. And the reason for that is the behavioral immune system. So this is kind of an emerging concept in psychology that I am fascinated with. A system of psychological mechanisms that detect cues to the presence of infectious pathogens in the immediate environment. So a system that lets us detect if there's a source of illness and trigger disease-relevant emotional responses, fear, anxiety, disgust, and thoughts that promote response or avoidance to these cues. So one way the behavioral immune system would have you act right now, hopefully, if it's functioning well, is I'm not going to go near that crowd, or I'm going to stay the heck away from that person sneezing. And if you have a higher, so it's called perceived vulnerability to disease, in other words, you perceive yourself to be more at risk, you're actually more likely to overestimate the threat. So maybe if you think that if you're really worried about getting sick and you do an action that actually really wouldn't put you at risk for getting COVID, you actually are more likely to think that it might. So you are more likely to have a false alarm bell that, oh my gosh, this is a dangerous situation, if you are more worried about yourself getting sick. Behavioral immune system is good. We should not be going in crowds right now, but it can also set off too many false alarms and actually prevent us from doing things that make us happy, even when they are safe. So anxiety sensitivity is one part of the behavioral immune system, a system which activates appraisals of changes. So it's essentially, you know, that feeling when you wake up in the morning and you have a little leg cramp and you're like, oh my gosh, do I have COVID? That's what anxiety sensitivity is. And the more sensitive, so the more likely you are to have one of those sensations and perceive it as dangerous is anxiety sensitivity. So anxiety sensitivity is increased due to fear of contracting COVID. And like I just mentioned, it's a body check, then a response is part of it. So, oh my gosh, my foot hurts. Do I have COVID? Even if, you know, as I wrote in there, I know I can't have this. I haven't left my house in weeks. I can't have COVID. But you still have this alarm bell going off in your brain, even though you know it's not rational, which is kind of in relationship to OCD. Sufferers know it might not be rational, but you still have these alarm bells and you still act on it. So individuals with OCD do have higher anxiety sensitivity as well before COVID. And one interesting point, and this is the am I sick versus the am I sick, is the presence of mental contamination. So when someone with OCD has a thought worrying that they might get sick, they actually feel contaminated mentally, and it relates back to their sense of self. So not only for someone with OCD, and again, talking about pre-COVID right now, let's say gets the intrusive thought, am I sick? They're going to relate that thought to their sense of self. If I'm sick, what does that say about me? Like, who am I as a person? Or going back to my thoughts, like if I have the thought that I want to cheat on my girlfriend, which again, would never ever do because I have no desire to, that would be a horrible thing. But what's that say about me? And that was the tremendous guilt that I felt. So while there are a lot of parallels between what people are dealing with in terms of anxiety sensitivity right now, OCD goes a further step and relates that to one's identity, which a lot of people, unless you have OCD, really aren't dealing with right now. Then disgust propensity and sensitivity. That's the second picture. So disgust propensity is the likelihood of feeling disgusted. Disgust sensitivity is the likelihood of interpreting something as disgusting. Like, you know, that sneeze. You see that sneeze, that picture, as way more disgusting now than you did before. I'm sure you thought it was disgusting before because we had this behavioral immune system before, but now it's even more so. A higher pre-pandemic disgust proneness is associated with higher pandemic anxiety. I think in this one study, they started studying disgust in like 2016, and they did a follow-up during the anxiety or during the pandemic, which is a really kind of a cool paradigm. Increased feelings of disgust are implicated in individuals with OCD. Not a ton of clear-cut research on that. This is a little bit of a helter-skelter similarity, but there has been a lot of research on disgust in OCD. I'm sorry if I'm rushing right now. I just want to make sure I can get through everything. And like I've said, mental contamination is one of those key differences. You know, if I have this disgusting thing, I'm disgusting. You know, what does that say about me? Who am I? And that's some of those feelings of guilt that can be associated with OCD. So briefly shifting to treatments, specifically those not pharmacological, like I mentioned, SSRIs are a first-line treatment that have been proven to significantly help individuals with OCD. But like all mental health conditions, therapy in combination with medication is better. So cognitive behavioral therapy is learning to recognize unhealthy patterns of thought called cognitive distortions. I'll talk more about those in a second. Exposure response prevention is essentially learning to have those alarm bells go off in your head and not respond to them. Because I have alarm bells go off in my head all the time and there is nothing wrong. And so you practice jumping into the thing that's making you anxious. Let's say it's touching doorknobs because you're worried about getting sick. The treatment is touching a doorknob. It's torture. It is really, really hard. And it scares a lot of people away, but it's really effective in the long run. It is scary, but the thing you do with OCD is jump into the fear. Mindfulness. I meditate every day. Well, I should be. I fall back sometimes. But it's noticing the world around you, essentially paying more attention to the world outside your head than the world inside your head. Meditation and yoga have been proven to be effective add-ons for OCD treatment. So mindfulness helps me tremendously, and so do CBT and ERP. Oh, and then lifestyle and sleep. The things that keep any given person healthy also keep people with mental health conditions stay mentally healthy. Like I said, if I stop exercising and sleeping, my OCD immediately starts to get worse. It's like clockwork. So really briefly, I'm going to talk about some cognitive distortions. I'm just going to talk about like a select couple of these, like all or nothing thinking things are either this way or that way. That's happening a lot right now. I'm either going to get COVID and be asymptomatic or I'm going to die. I am either doing enough or not doing enough to stay away from COVID. Someone's acting wrong or someone's acting right. It takes away all the gray, when in reality, life is shades of gray. Jumping to conclusions, thinking that there's a foregone conclusion because of something, even though I have not met anybody that can predict the future yet. None of us can. And so that's another cognitive distortion. Catastrophizing, this is one that I'm prone to, blowing things out of proportion, making a mountain out of a molehill. These are all cognitive distortions that can be associated with OCD. But importantly, everyone can have cognitive distortions, and everyone does have cognitive distortions. They just so happen to be more prevalent in disorders like OCD. So these are things all of us deal with on a regular basis. And that's why cognitive behavioral therapy is so awesome, because it can teach individuals outside of those who have OCD about how they're thinking. This is a quick note. Treating irrational fears when they're irrational. Yeah, someone who's worried about getting sick, they're a little bit more justified in that fear during this than they were before the pandemic. So a bunch of practice guidelines have come out for OCD therapists to how to do exposure response prevention therapy during this. It's hard. You have to make some modifications, but it's still being done. And some of those references I encourage you to look at if you would like to know more about those practice guidelines. So quickly, what can OCD teach all of us? Thoughts are not reality, even when reality is scary. Just because you have the thought that I'm going to get COVID doesn't mean you will. You should still be concerned. We are living in a pandemic and our behavioral immune system is a good thing. But I've met a lot of people who are taking away from their own happiness because they're being unnecessarily cautious. Though the alarm bell might be going off in your head, that doesn't necessarily mean it reflects reality. There might not be as much danger as you perceive. Mindfulness. Living in the present helps people with OCD. It helps everyone in the pandemic. Everything I've read about meditation and mindfulness has shown that it can be beneficial to everyone across the board. It takes you out of your head and it helps you focus on what's in front of you, not only in the present time, but in the present place. Because the present time is a scary time, but if you don't see anyone with COVID in front of you and you're in a healthy, safe spot, focusing on that moment can help your mental health tremendously. And like I said at the end, sleep and exercise. We got to take care of ourselves right now. It's more important than ever. So some acknowledgements, the UNC MD PhD program, they are fantastic. I love being here. There's some phenomenal people at this school, and I am very grateful to be here. I started reading this book, which came out in October 2019. I said nobody can predict the future, but the only man that can is Stephen Taylor, because he wrote a book about the psychology of pandemics in October 2019. It is a fantastic book. I used a lot of what I learned from it to inform this presentation. And it has given me so much more insight into not only my own, but to everyone else's response to it. And that book is what really introduced me to the behavioral immune system. Then NAMI Illinois, NAMI Chicago, who I worked with when I was back home. And now I work with NAMI Wake County here as their Ending the Silence coordinator. And then you can follow me at any of these links after the presentation. I know it's free for download. Just broke 1,000 monthly listeners on Spotify for my music stuff. So would love it if you follow me there. And I am happy to answer any questions.
Jeremy, there's a question about, or a request if you could talk a little bit about the stigma of getting COVID for a person who has OCD.
Okay, I'll try to tackle it. I think I get what that question is asking, and Al, if you want to, feel free to clarify if you want, but I'll try and tackle it. I think what that's asking is someone with OCD might be more worried than somebody else about acquiring COVID. Part of what I talked about earlier was things that are hard for all of us are particularly harder for things with people with OCD. For me personally, my OCD has nothing to do with getting sick or contamination. So that threat from COVID doesn't feel any scarier to me than it does to the normal person in particular. However, like that small Italian study I mentioned, those with contamination related OCD do feel that threat very acutely right now. Some people more so than others. I don't want to make a big generalization about it because, I've talked with friends with OCD who are just kind of continuing going along their merry way through this. For me personally, what's really affected me was like having nothing to do, like shortly after the pandemic hit, because I had to leave my job at the time and I had a lot of free time on my hands. I'm not able to see my friends as much. They're my social support network. So that's one of the things when someone thinks of OCD during the pandemic, part of it is there are a subset of people who are more worried about getting sick than normal, but a lot of it is like the loneliness, the isolation, the grief, and the anxiety that a lot of us are experiencing right now. So thank you for that question. It's a good question. Oh, that's a good question. Comments on why certain folks get specific types of OCD intrusive thoughts, nature, nurture. There has not been a ton of research on that. That is that's a research question. That's like one of the questions I would like to see most answered. Why my OCD took on themes about relationships, I have absolutely no idea. So no one else in my family has had OCD about relationships. You might think that like early childhood experiences might play into it, but there really has been no research, and it's the medical word is idiopathic. We got no idea. So yeah, it's an interesting question. A brief addendum to that. There are times in life where OCD is more common than others. Postpartum OCD is one of the most common presentations, and very few people know about this. It's very scary. I think every mother to a newborn has had a thought, oh my gosh, I want it to shut up right now. Like, I'm just going to throw it out the window. I don't think I hope to God that there has never been a newborn mother who has acted on this, but you have these heartbreaking situations of mothers thinking they are a danger to their own child and refusing to go near the kid because they have these intrusive thoughts that they're a danger to their child, and they care so much about the kid that they refuse to go near it because they're worried they're a danger. There's some truly heartbreaking stories about that. So unfortunately, that's all I can say to answer that question. I wish I could give you more. Hopefully in the next 10 years, we get a little more. Do OCD treatments work with typical teen social intrusive thoughts that can be dysfunctional? I think I have the ability to unmute people. Murray, if I unmuted you, would you mind clarifying that a little bit? Maybe. Otherwise, I can try and tackle it. Typical teen social intrusive thoughts that can be dysfunctional. I think that what that's getting at is kind of like a social anxiety paradigm. OCD is actually most likely to present in late adolescence. So I was 19 when my OCD presented. Oh, here, Murray, I will unmute you if you want to talk.
Yeah, I don't think we have that ability, Jeremy. It says that we do, but I think the conference overrides it.
Can you hear me?
Oh,
yeah.
what? Never
Yeah,
mind.
Murray.
That is true.
Yeah, what's your question?
Teens with typical social intrusive thoughts like rejection, or violence toward peers, or violence toward themselves, that sort of thing, which can all be functional and cause like school refusal, etc.
Sure. Yeah. Okay, that makes more sense now. Thank you for clarifying. I appreciate it. I don't know if I'm able to unmute you now. Sorry, I kind of did that without fully knowing. You might have to mute yourself again. Thanks. Yeah, so that can be, in my clinical experience, I've worked with some patients with OCD that were teens, and that fear of hurting others can play into school refusal. That's a reasonable thought. Those fears of rejection can also play into OCD. OCD is very commonly associated with depression, and teens are at a very vulnerable time in their life where they are still forming their identities. And you can imagine if a teenager starts having these thoughts, whether in this vulnerable state of identity formation, what's that say about me? Like, I'm a horrible person. I'm trying to think if I could say anything else to that. The one resource I would recommend watching, and where there are some teens that do talk about their OCD, there's this fantastic documentary on OCD called Living with Me and My OCD. And they interview just tons of OCD sufferers, including some teens. There were teens that had to leave school because their symptoms were so intense. And there were teens that were bullied because their OCD was really heartbreaking. But I would recommend that you watch that. I'm sorry, I feel like I couldn't fully answer that, but that's what I got.
Do we have any other questions for Jeremy?
Please ask more questions so I don't have to go back to studying oncology.
For the participants today, at the conclusion of the session, at the bottom of your screen, there will be an option to complete a survey. And so we're hopeful that you'll complete that. Also, when you're on your screen, where it says chats, people, polls, there's also, I'm drawing a blank now. There's an option to view the presentation today, and that option will be available to you for a year.
Yeah, absolutely. Thank you, Mary. And like I said, with the presentation, all those resources are, I put them all in the footer so you can click them. They should all be open access, but please feel free to email me if they're not, there's something you'd like to read. OCD is very underdiagnosed. Yes, thank you. I'm glad that you thought it was helpful. OCD. What should someone with OCD do in the moment of intrusive thought? And Betty, I will direct that question to Tina after I answer this question. You're welcome. In the moment that one has an intrusive thought, so that's the moment where your spider sense is going off. And there's a couple options. A lot of it is, stepping back and saying, okay, it's diffusing that thought from yourself. Imagine all your alarm bells going off at an improper time. What you have to do is learn to recognize that, say, okay, label it as, hey, this is just an intrusive thought. I do not have to dive into this and start doing compulsions in response. That's harder for someone like me who has covert intrusive thoughts, covert compulsions. All the things I do in response to my intrusive thoughts are in my head. In comparison to somebody who has the intrusive thought, I'm going to get sick. It's a lot easier to stay away from the sink, not wash your hands. Whereas for me, sometimes I can do compulsions without even realizing it. If I'm not super quick to identify that intrusive thought and distract myself and, do something completely different, meditate, focus on schoolwork, play music, hang out with a friend, anything, or just breathe through it. The great thing about meditation is I use it throughout my daily life. if I have an intrusive thought, I'll just focus on my breath for a second, then go back to whatever I was doing, because, like if I'm doing work, I can't really afford to just like dive into an intrusive thought, nor do I want to. It's very uncomfortable. I hope that answers your question, but it's a little different for everybody. Does Asperger's syndrome increase OCD or increase intrusive thoughts? That's a good question. So autism is actually very tightly linked with OCD. The two are, that is a frequent comorbidity, no problem. And well, we see the two together very frequently, especially in boys. OCD is more prevalent in boys also, as is Asperger's or autism spectrum disorders, as we usually now call them. So yeah, that's a good question. Yeah, and then Tina, somebody asked where they find the materials.
So following the conclusion of the conference, many of the sessions will be available on YouTube, but the link that brought you into the conference sessions, and then when you click on the actual session itself, there's a screen that comes up, and you can click on the files, the tab that shows on the screen, and the session that will be available there. And I'm told that all of that will be maintained for up to a year. So lots of opportunity if there are sessions that you weren't able to see that you'd like to go back, if there's sessions that maybe had a lot of technical information or some other links or referrals that you think, oh, what was that information? Lots of time to go back and review and capture that information.
Like I mentioned too, all those social media things, those are actually clickable links. So you can just click on those and it'll take you right to my page.
Okay.
Thank you, everyone.
I'd like to thank you, Jeremy, for your information. Excellent presentation. And thanks to all of you who participated today. We were glad to have you here, and enjoy the rest of the conference.
Oh.